Quick note, I don't have the fancy mic and my computer is being fucky, so I'm so sorry if the audio just gives up halfway through this. So we are still talking about diabetes because of course we are. So we're just going to talk about clinical science and complications. And to begin with, we're going to talk about what is diabetes, right? So diabetes is primarily hyperglycemia, which just means too much fucking sugar in your blood. And this is what leads to the whole array of complications. And chronic hyperglycemia has these characteristic microvascular complications in the eyes, in the kidneys, and the nerves. And these are referred to as diabetic retinopathy, diabetic nephropathy, and diabetic neuropathy, respectively. Okay, so that was a bunch of medical nonsense. What does that actually mean? It means that diabetes is the leading cause of blindness in the working age population. It's the leading cause of end-stage renal failure, leading to patients being on dialysis for, the rest of their lives. And it is the leading cause of non-traumatic lower limb amputations. Gee, Yara, I thought you said this video was gonna be fun. Well, I lied to you. Don't worry, you get used to it after a while. Okay, so I said that there were characteristic microvascular complications, but what the hell did I mean by that? In diabetes, it means that patients develop this thing called hyaline arteriosclerosis. Hyaline just refers to the pink, glassy quality when you stain the vessels to look at them under microscopes or whatever weird other magic shit that histopathologists do, and, they understand that and I do not. What's important is that diabetes causes the specific kind of thickening of the walls of their arterioles, and that alters their permeability and their strength. And it would be logical, I can see your thinking, it would be logical to say, hey, they get thicker, so the problem is that they're too strong and they don't let anything through. But you know what? Fuck, man. What actually happens is the vessels become weak and leaky. Do not ask me why. I do not know. So, yeah. The long and short of it is that chronic levels of hyperglycemia are not good for you. And you'll notice I said chronic hyperglycemia. Now, DKA and HHS they're definitely bad for you, but it is the state of being persistently hyperglycemic that actually causes these complications. And that's why the single most efficient and accurate predictor of mortality and complications in a patient with diabetes is HbA1c. And that's also why glycemic control in diabetic patients is so specifically focused on keeping that HbA1c number as low as possible. Let's actually talk about the complications and how they happen. As a quick reminder, a lot of the symptoms of diabetes mellitus are really non-specific, right? They're polyuria, polydipsia, polyphagia, fatigue, poor wound healing, blurry visions, right? And these are symptoms that prompt you to investigate and ultimately diagnose a patient with diabetes mellitus. Now that those patients have been identified, what is it that we're worried about? Let's start with nephropathy. So nephro means kidney, which means what we're about to talk about is going to be happening in your kidneys. And the kidneys are important because they are basically responsible for, filtering waste out of the body, for keeping your body fluid volume and your osmolality correct, and your acid-base equilibrium. It also does some hormone synthesis, but don't worry about it. Okay, so diabetes, it fucks up your kidneys. Boom, video done. Sorry, I'm kidding. I will explain it. So, as always, we start from chronic hyperglycemia, and this is going to cause glycation, or also known as non-enzymatic glycolization, or NEG, of the basement membrane, right? And the basement membrane is just a thin layer of extracellular matrix in the kidneys to which cells can anchor. It's basically, it separates the epithelium from underlying connective tissue. So this glycation causes increased permeability and thickening of the basement membrane, as well as stiffening of the efferent arterioles. This leads to hyperfiltration, or an increase in glomerular filtration rate. Why does it do this? We don't really know. It just does. The mechanism behind hyperfiltration is really not fully understood. Dilation of the afferent arterioles appears to play an important role, and there's a variety of hormones and tubuloglomerular feedback loops that are involved, but we don't really know, because this is medicine, and if we had answers, it would be a lot easier. So anyway, increase in intraglomerular pressure leads to progressive glomerular hypertrophy, right? Because they're working really hard to kind of come back at that pressure. And this increases the renal size, right? The literal size of the kidney, and it will cause glomerular scarring, which is known as glomerulosclerosis, right? Which will make them stiffened. All of which basically combines together to cause a worsening of filtration capacity. So this, oops, I'm sorry, I was really shaky, I'm sorry. So this takes time, right? This is a complication of chronic hyperglycemia. So we see this with patients who've had hyperglycemia for about, greater than or about 10 years. Now you might be thinking, okay, cool. So we don't need to worry about this when we're diagnosing patients. However, you have to remember that type 2 diabetes goes undiagnosed for a long time. So it is important to screen patients for, renal complications on their first presentation, because they might have been having hyperglycemia for many, many years before you actually catch it. Right, and for the pathologists out there, there are some characteristic histopathology changes. There are specifically 3, right? You get this thing called mesangial expansion, and no, I don't actually know what the fuck that means either. Good for you. You also get, glomerular basement membrane thickening, right? Kind of like what we talked about before. And then you get this glomerulosclerosis, right? And that's in the later stages. So you can have kind of diffuse hyalinization of the glomerular capsule, or you can have this pathognomonic, I don't know how to say that word correctly, but these characteristic nodular glomerulosclerosis, right? And these are called Kiemelstein-Wilson nodules, right? And they're very characteristic. You see them specifically in diabetes. If none of that made any sense to you, don't worry about it. You're not going to become a pathologist, but pro tip, neither am I. Okay, cool. So now we know that shit is happening in the kidney. How do we stop it? Now, you need to reach back in your brain, back into tests that I was talking about. And, this is an additional test that we're going to do. And this is why we assess for albuminuria, because it gives us an understanding of the relative health of the kidney, right? If you have microalbuminuria, right, that is a sign of, progressively worsening kidney problems. Now, if you have macroproteinuria or significant amounts of albumin in the urine, that means that the kidney is failing. So first things first, strict glycemic control may delay the progression of this kidney complication, but it can also sometimes even reverse diabetic neuropathy, in the early stages. So obviously our big treatment push is strict glycemic control. Keeping your patients at or below target HbA1c is super critical in terms of long-term health and preventing complications. And these patients are most likely going to be asymptomatic in terms of their kidney problem, right? They might have something like, oh, my urine was a bit foamy, but let's be honest, not a lot of people pay that much attention to their pee. Let's be real. And the other big symptom is hypertension. Now, the problem with that is pretty much after a certain age, everyone has hypertension. Still, another important treatment modality is controlling hypertension, right? Good antihypertensive treatment is important for controlling complications like neuropathy, and ACE inhibitors, which are angiotensin converting enzyme inhibitors or angiotensin receptor blockers, aka ARBs, are typically the first-line treatment, antihypertensive treatment drug in patients with diabetes. So we really focus on ACE inhibitors specifically because ACE inhibitors prevent the progression of microalbuminuria, and they seem to have a protective effect specifically against renal tubular interstitial fibrosis. And they have this sort of protective effect even if the patient doesn't actually have hypertension, right? Let's say, you have this diabetic person, you have signs of this nephropathy, but they are not actually hypertensive, which is crazy rare, but it happens. ACE inhibitors still seem to help in terms of delaying or slowing the progress of nephropathy. Our second line agents that can be added to ACE inhibitors are ARBs. In this particular instance, to try to further control hypertension, are going to be like diuretics or calcium channel blockers. And in the later stages, we talk about diet modification. Now, the reason why you might be thinking, why wouldn't you just start with diet modification, is because these patients are diabetic. They're already on pretty strict diets and trying to restrict, bring down their daily salt intake to less to 5 to 6 grams a day and modify or make sure that their phosphorus and potassium intake is restricted, as well as protein restriction on top of trying to keep their glycemic levels correct. That's really hard, and just give them an ACE inhibitor, okay? Okay, so we're done with one complication. Let's talk about the second. We're going to talk about retinopathy. And so after about 15 years of the disease, approximately 90% of type 1 diabetic patients and, about 1/4 of type 2 diabetic patients are going to develop diabetic retinopathy, right? So this is the most common cause of visual impairment and blindness in patients aged 25 to 74 years in the United States. And the symptoms are, it starts off asymptomatic until pretty late stages. This is why screening is so important. And then it'll go kind of visual impairment, and then it'll progress into blindness. And again, this is why diabetic patients need to get their eyes checked every year, regardless of whether or not they have any symptoms. Okay, cool, Yara, I'm checking the patient's eye. What am I looking for? What do I find? So you'll either find proliferative retinopathy or you'll find non-proliferative retinopathy, which is the more common kind. And your findings in non-proliferative retinopathy are going to be intraretinal microvascular abnormalities, or IRMA, including like little microaneurysms. You're going to find caliber changes, right? Changes to the width and the size of the venous vessels in the eye. You're going to find signs of intraretinal hemorrhages, right? Hard exudates in the retinal edema, and you might find these things called cotton wool spots. And then your big finding is vision loss, most commonly due to macular edema. In proliferative retinopathy, you're going to find pre-retinal neovascularization, right? That's the hallmark for proliferative retinopathy, which basically means you're going to see the development of new vessels in the pre-retinal area. And this is the big distinguishing sign of proliferative retinopathy. It proliferates vessels. Okay, so you get, fibrovascular proliferation, you get vitreous hemorrhage, you get tractional retinal detachment, you get rubiosis iridicis, whatever that is, and then you can get secondary glaucoma, and then you get all these additional findings because you can get the findings of non-proliferative retinopathy with proliferative retinopathy also. And then in this case, you'll have patients who are developing vision loss, and that's usually due to either the vitreous hemorrhage or a retinal detachment or a glaucoma. And then your big finding that you're going to find in both, whether or not it's proliferative or non-proliferative, and is not stage dependent, right? It doesn't have to be early. It can be, or late. It can just kind of come up whenever. And that's macular edema. And that's clinically significant retinal thickening and edema in the macula of the eye. And then you get these hard exudates, and then you get ischemia because, things going wonky. If that didn't make a ton of sense to you, don't worry about it. Diabetes, it fucks up your eyes. The good news is there are some treatments. So in the instances of non-proliferative retinopathy, you can get this laser treatment called focal photocoagulation. And then you can also get an intravitreal, antivascular endothelial growth factor injection. Yeah, don't worry about it. And then in the instances of proliferative retinopathy or very severe non-proliferative retinopathy, you have also the option of a laser treatment, but this is a pan-retinal photocoagulation. It's going to take a bunch of appointments. And then there's some risks associated with that because you can end up with night vision impairment or actual loss of the visual field, or just further fibrosis leading to an increased risk of retinal detachment. And then you can also, there is a surgical option where you get a vitrectomy in the cases of, the retinal detachment or a vitreal hemorrhage. All in all, not very fun. Or the treatment for the macular edema, which is pretty much the same as the non-proliferative retinopathy, which is just either focal photocoagulation or the VEGF inhibitors. Whew, okay, so that was diabetic nephropathy and diabetic retinopathy, respectively. Let's talk about neuropathy. So how does the neuropathy happen? Basically, you start with chronic hyperglycemia, obviously, because this is still a video about diabetes. So you start with chronic hyperglycemia, and this causes glycation of axon proteins with subsequent development of progressive sensoromotor neuropathies, typically affecting multiple peripheral nerves at once. And in English, instead of medicalese, that basically means the chronic hyperglycemia causes the sugar to mess up the axons of nerves, which causes neural defects because, the nerves are ganked. And diabetes is the most common cause of polyneuropathy in Western countries. But what does that actually mean? Like, what does that look like in patients? So usually the early sign is sort of a progressive but symmetric loss of sensation in the distal lower limbs and like the lower extremities. So starting at the feet. And it's usually caused a stocking glove sensory loss pattern with proximal progression, right? Which is to say it starts at the bottom of the feet and it goes up, and you're kind of first notice it in the area that might be covered by stockings or gloves. Because so many people be wearing stockings these days. And again, so these patterns usually occur starting at the feet. Now, you can get a similar sensory loss pattern occurring in the upper extremities, but it makes sense that it normally targets the feet, right? Because the hyperglycemia affects the axons of cells, and the longest axons are going to be in the nerves that reach to the distal aspects of the limbs, and particularly, the nerve that reaches all the way down to the feet. So later signs of this kind of neuropathy can be pain at rest or at nights, which is just called painful diabetic neuropathy because it's, a neuropathy, but it's painful. But you also get this decreased pain perception, and then you get motor weakness, and then you get areflexia or diminished reflexes in the limbs. Great. Okay. Not that bad. Like, cool. We're done. Jokes. You will notice I said usually. So there are special types of neuropathies, right? So it doesn't always start at the feet and progress up. Although, again, it usually does. You can also get mononeuropathies, and I could talk about this for a long time, but I would really like to stop talking about diabetes sometime in the next 40 years. So just accept that you can get specific cranial nerve damage or specific peripheral nerve damage, right? Single nerve gankery. And this is usually in the cranial nerves or the hands. You can also get autonomic neuropathy. And if you don't know what I mean by an autonomic nerve, go Google it. I am not your mother. Autonomic neuropathy can be broken down by the system it affects, right? So starting with the ureterogenital system, right? You can get erectile dysfunction, which is actually the most common sign of this autonomic neuropathy, obviously in men. But then you can also have bladder dysfunction, which will be urinary retention or incomplete bladder emptying or bladder distension or outflow incontinence or just poor urinary stream. Not fun at any point. You can also get autonomic dysfunction of the cardiovascular system. And this is very important because what can happen to diabetic patients is they get this thing called silent myocardial infarctions. Because what's happened is the nerves that innervate the heart and innervate the area of their chest have been damaged, so they have diminished sensation. And then they suffer an MI, but they don't get chest pain. They don't get the sensation of crushing. So they have secondary symptoms, things like nausea, vomiting, or diaphoresis, but they don't recognize it immediately as an emergency, as the fact that they're having a heart attack. So they tend to present later to the emergency department, if at all. And this obviously has problems for their long-term outcomes. There are other problems associated with the cardiovascular system, which can be things like ventricular arrhythmias or just persistent tachycardia, which is too fast of a heart rate. But they can also get this thing called decreased heart variability, or what's referred to as a fixed rhythm, which is to say your body doesn't compensate for things as well because your heart is kind of stuck beating the same way, which sometimes your heart needs to race. Like sometimes you need that jump. For example, they'll have orthostatic hypotension, which means that when they go from sitting to standing, their blood pressure will drop because their heart wasn't able to compensate. So the other system that can be involved in autonomic neuropathy is the GI system, which is very important because what can happen is you get gastroparesis, which is functionally just paralysis of the gastrointestinal tract, and this will lead to delayed gastric emptying. And this is important specifically in diabetic patients because it increases the risk of postprandial or post-eating hypoglycemia, right? Because they're calibrating around the food that they're taking in, but the way that their body responds to that food has totally changed. They can also have signs of nausea, kind of bloating. They might have loss of appetite, or they might experience early satiety, which is just like, you take 2 bites and you feel super, super full. You can also have diarrhea, constipation, incontinence, right? So treatment for that are prokinetic agents, like things that help increase gastrointestinal motility. And then you can have other manifestations of autonomic neuropathy that are a little bit weirder. So that's going to be sweat gland dysfunction, specifically associated with heat intolerance, which I'm going to be honest, sometimes I wish that I didn't sweat, but it is a medical problem and it does need to be looked into. You can also have pupillary dysfunction, which means that they'll have difficulties adjusting to changes in light. And then you also have this risk of hypoglycemia that can happen because what's happening is the hormonal system of the body has a counter-regulation, and you can have secretion of oversecretion or randomized secretion of cortisol or glucagon or other hormones. And I will touch a little bit more about that in therapeutics because yes, I will need to make a whole other ass video about diabetes, and I apparently will never ever stop talking about this disease. Okay, so before we do a different video on therapeutics, I am going to talk a little bit about treatment specifically for neuropathy, and that's pretty much, again, optimal glycemic control. Keep that HbA1c well controlled, and you don't have to worry about the neuropathy because they won't develop it. I mean, they will, but we're talking about that. And then the other thing is pain management, right? This can be extremely painful and extremely uncomfortable for these patients. So you're going to want to give them, anything in the range from NSAIDs to opioids. And then finally, what you might also see is patients will receive anticonvulsants to help with things like the tremor, usually pregabalin. It's the most effective, so it's usually first choice, but it can also be gabapentin or sodium valproate. And then finally, you might also give these patients antidepressants, specifically tricyclics like amitriptyline.
I'm not good at pronouncing drug names.
But you can give them really a whole suite of antidepressants, and most of that is because a lot of the hormones associated with depression and mood are also actually associated with smooth motor control. So they kind of help with neuropathies. Okay, and the final complication is there is also this thing called diabetic foot. But this video is already a nightmare, so don't worry about it. What you want to know is that diminished sensation in the feet can lead to ulceration of the foot, and it can also lead to neuropathic arthropathy, or Charcot's foot, which is just a really fancy way of saying that the joint and bone formation of the foot gets fucked up. And this is why it is so important for patients with diabetes to check their feet, because they will not feel these changes occurring. So good footwear, regular wound dressing, and sometimes surgical debridement are all going to become staples for these patients. And patients will often also end up on antibiotics, right? Because foot ulcers can become easily infected. And if this doesn't work out, if they're not able to receive appropriate and attentive medical care, if they live alone and they can't reach their feet, they can't see their feet, they can develop life-threatening complications from this and, specific infections that can be really, really difficult to treat. And ultimately, poor control of this complication will lead to amputation. So that's fun, I guess. So anyway, this video obviously got a million miles away from me. Prayer circle that it is still under 30 minutes. But the important takeaways is that we were able to talk about the major complications of diabetes, which again are nephropathy, retinopathy, and neuropathy, and then also special consideration for diabetic foot. And hopefully I will see you next time to talk about therapeutics.
Second prayer circle that I get the mic back.